Welcome, everybody. Thank you so much for joining us today. The Community Rounds workshop series has been on hiatus for a while, so we are very happy to be back with you. My name is Jennifer Noel, and I am the program manager for the Education and Outreach Core at the University of Vermont Center on Rural Addiction, which we call UVM CORA. UVM CORA is also a rural center of excellence on substance use disorder treatment. And I'm here with Center Director Stacy Sigman and Education and Outreach Research Assistant Eleanor Broy, who will be helping to facilitate this webinar. We also have some other panelists for this session, and we will introduce them shortly. As you are entering, your cameras are automatically turned off and you are muted. Today's webinar is entitled From Insights to Action, Identifying Needs for Rural Substance Use Disorder Training through Healthcare Professionals Listening Sessions, presented by Drs. Lindsey Smith and Gail Rose. The Community Rounds workshop series is a live webinar series that UVM CORA hosts regularly. Our goal is to provide opportunities for health professionals and community partners to learn and ask questions. And we discuss topics related to science-based best practices for substance use disorders. And now I have just a couple of reminders to go over about today's webinar. We do encourage you to ask questions. And there'll be several experts on hand to answer them today during the Q&A period following the presentations. So please enter your questions into the Q&A box, which I think used to be at the bottom of your screen. And now you might find it if there's 3 dots where it says more at the bottom of your screen. If you click that, you'll probably find the Q&A box to use. We will review your questions during the Q&A period at the end, and the session is being recorded, and the recording will be delivered to your mailbox next week. We also want to let you know that after our speakers have finished their presentations, and just before we have our Q&A, we will share a very short poll to assist us with our evaluation, and you're going to see that right in the center of your screen. It's so helpful to us when you fill that out. If you would like, please use the chat box to introduce everyone or introduce yourself to the group by sharing your name, your organization, and your community that you're coming from. And we also are grateful for any comments that you'd like to share in the chat about the webinar itself. Be sure to select everyone when you use the chat feature so that other participants can see your comments. Live captioning is available for today's event, and to access the captions, please see the chat. You will find a link there. Continuing education credits are available for those who attend the session live and for those who watch the recording within 1 month of the live event. During the session, we will share the link in the chat box for instructions on how to claim your credits, and you will get these same instructions via email when you receive the recording. If you have any questions, you can always contact us at cora@uvm.edu. And there are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So I am going to stop sharing and allow Dr. Smith to share her screen. And while we're doing that, I would like to introduce Dr. Stacy Sigman, who will be introducing our speakers and our panelists today. Dr. Sigman is the principal investigator for the HRSA grant for the University of Vermont Center on Rural Addiction. She is a tenured professor of psychiatry at UVM and a researcher with the Vermont Center on Behavior and Health in the Larner College of Medicine. Dr. Sigman, I will hand it over to you.
Thanks so much, Jenny. Welcome, everyone. It's really great to see so many people here with us today for our session, and I'm really pleased to welcome our speakers for today. First, we're going to have Dr. Lindsey Smith. Lindsey is a colleague of ours and a director of substance use research and evaluation and a senior research associate at the University of Southern Maine. She is also responsible for designing and implementing health services research and evaluation projects that are related to addressing substance use disorder. And Lindsey also has extensive research and clinical expertise in the areas of substance use and behavioral health disorders. And these have been kind of the primary focus of her research for the past 2 decades. And finally, last but not least, she's also has extensive experience designing and managing research and evaluation projects at across the local, state, and federal levels. Next, we'll have Dr. Gail Rose, which is our colleague here at UVM, an associate professor in psychiatry. And Gail is also the director of our UVM CORA clinical and translational core, as well as our best practices core. And as a researcher, she's directed and contributed to projects really broadly focused on clinical health services, patient self-directed care across areas of behavioral health and substance misuse. And in particular, Gail's work is focused on the application of a range of technologies to identify and treat substance use in outpatient settings, as well as on the integration of behavioral health in primary care. In addition to our two primary speakers for today's session, we will have several panelists joining us later in the webinar. And these folks will be available at the end of the session to help answer questions that come up in discussion. Katie Rosengana is a research associate at the University of Southern Maine, and she collaborates with Dr. Smith extensively. And Doctors Peter Jackson and Brady Heward, as well as Elizabeth Tansey, all serve on our UVM CORA scholarship and support team here at UVM. And so without further ado, I'll now happily turn things over to Dr. Smith. Lindsey, it's all yours.
Thank you, Stacy. Oh, I went a little bit too far. Before we start today, I just wanted to ground us in our learning objectives. So we're going to start off. First, I'm just going to give a little bit of background about the UVM Center on Rural Addiction, and then we're going to move into discussing the key goals and methodologies that we used in our healthcare professional learning sessions, and summarize some practical insights and lessons learned from the field. We're also going to then move into Gail's piece, where she's going to describe the training and scholarship support and explain how this feedback that we got from the listening sessions was used to inform the training and scholarship program resources and activities. So approximately 58% of people aged 12 and older use nicotine, alcohol, or illicit substances in the past month, and nearly 17% report having a substance use disorder in the past year. There are differences in urban and rural areas. There's some areas where they coincide, but in areas where rural areas do experience greater burden. For example, only 1 in 5 individuals who need substance use treatment actually receive that. And those rates are lower in rural settings where they experience more challenges to access for initiation and engagement. Since 2020, when we started the center, their rates involving psychostimulants are high, and those involving natural and synthetic opioids were also 13% higher in rural communities. So the Center on Rural Addiction is really designed to address some of these additional challenges that are experienced in rural communities for addressing substance use disorder. Some of these challenges included, and I'm sure this isn't new to anyone on this call, are limited access to provider and treatment services. Transportation and geographic isolation really cause a hindrance to accessing care. We also hear a lot in the field about stigma and lack of anonymity, which creates hesitancy to seeking care because of concerns about privacy issues. Obviously, there are workforce shortages in our rural communities that impact capacity, particularly around the behavioral health components of addressing substance use disorder. And some policy gaps still remain, including limited access for telehealth infrastructure in our rural communities, restrictive licensing for providers, and underfunded community programs. And finally, in rural communities, there are limited resources to address social determinants of health, which are really critical for initiation and engagement, as well as ongoing maintenance and treatment. So the Center on Rural Addiction was formed in 2019. We are on our second cycle of funding. And as Jenny pointed out, we are funded by HRSA through their Rural Opioid Response Program. We are one of 3 centers of excellence. And really the purpose of CORA is to support rural providers and healthcare professionals in their efforts to treat patients with substance use disorder, with an overarching goal of really trying to increase capacity to address substance use in our rural communities. And UVM CORA does this through a combination of strategies, including consultation, resources, education, and technical assistance. And then, of course, we have our surveillance and monitoring core, which this listening sessions were conducted out of, that really help inform our work and keep us up to date on current epidemiological trends in the substance use space. Our center objectives are to leverage expertise that we have across the center to identify real-time needs of communities and help implement science-supported methods to effectively address those. We do this through a combination of delivering ongoing technical assistance and workforce training, such as webinars like this, and then disseminating education and resources on evidence-based practices broadly through our website, listservs, and other mechanisms. The center is set up into 4 primary cores. So our surveillance and evaluation cores, which conducted our baseline needs assessment in the first cycle of our funding. And really the core is designed to assist providers and practices with establishing and developing data systems, as well as monitoring drug use patterns, as I just recently discussed. Our best practices core, which provides a lot of in-person and remote technical assistance training on evidence-based practices, and also provides hardware, software, and other resources that help expand evidence-based models for care and delivery. Our education and outreach core hosts these community round seminars, distributes newsletters, and really houses our resource library and keeps that updated. And then finally, we have our clinical and translational core, which provides consultation and peer mentoring. This is really a lot of that one-on-one work that our clinical experts provide. And this is where the work that Gail is going to present, our scholarship program lives, as well as our open office hours for clinicians. We have a large team. Just want to make sure we recognize everyone who is part of the UVM CORA team. We have partners from all over the country, as well as New Hampshire and Maine participating in this project as strategic partners that are located in northern New England. To date, CORA has supported over 35,000 rural healthcare providers across all 50 states. Nearly 13,000 participants have participated in our community rounds, and over 600 people have received CMEs for that. Our scholarship program and events have reached a number of clinicians across northern New England and more broadly nationally, distributing over 315 CME credits, and a total across all of our activities of 931 CME credits going out. You can see from our map here, we have broad distribution across the country. We've developed over 70 evidence-based tools, put out over 100 peer-reviewed publications, and done over 475 presentations. We have close to 3,000 individuals on our listserv and 14,000 plus website visitors across all 50 states every year. I also just want to give a shout out to our technical assistance and resources core, who you can see on the right-hand slide here. We have disseminated numerous supplies across our service area And that has increased over time as we have solidified the activities of our center. So these have provided invaluable, tangible resources to communities such as test strips, naloxone, and other supplies. Some of the persistent challenges that we face in rural communities are continued increases in fatal and non-fatal overdoses. We have insufficient mood treatment utilization. So despite national efforts to enhance access to mood, we still have providers who are under capacity in their patient panels, or areas where mood services are simply just not available. Continued increased morbidity and mortality related to psychostimulants is something that CORA has increasingly been moving into the space. And prevalent trauma and PTSD among individuals with OUD is prevalent in our data and something that we're working on addressing. There still remain practical challenges that undermine retention in treatment as well as access. And so we together as a unit at CORA defined 5 urgent areas for need that we were going to focus on with our pilot projects through 2013 and 2018, our current funding cycle. And that is really what we focused on gathering data from in our community or healthcare professional listening sessions, and they include enhancing access to mood in rural communities, understanding risk reduction practices, and increasing capacity for risk reduction. And as I just mentioned, with the increase in stimulant use, one of our areas is enhancing capacity for contingency management. And then finally, really focusing in on how we can provide resources and tools that effectively allow providers to address co-occurring disorders, and particularly trauma and post-traumatic stress disorder. So here's just a summary of our pilot projects, the Contingency Management Certificate Program, the creation of our PTSD SUD Toolkit, our Risk Reduction Toolkit, our Scholarship and Support Program. We're still working on our Telehealth and Transportation Connectivity Program, and then a joint project with the other rural SUD Centers of Excellence, creating a clearinghouse of resources specifically for rural communities, including patients, professionals, and providers that they can access. So a pivotal part of informing our work in our 5 pilot areas was conducting healthcare professional listening sessions. So I'm going to shift and talk a little bit about that right now. So when we were thinking about moving into the next phase of funding, we had conducted pretty comprehensive needs assessment in phase 1 of our funding, but we knew that there's evolving needs. And so what we decided to do was conduct healthcare professional listening sessions across northern New England, so in Vermont, Maine, and New Hampshire, with the specific goal of gaining up-to-date information on overall needs related to barriers and facilitators, to expanding access to treatment and services for substance use disorder. We also wanted to look at if there were state-specific needs or were there common themes across states. And the primary aim that we're really going to focus on today is how we used this information from the listening sessions to provide rapid cycle feedback to our pilot projects so that they could develop resources and trainings for rural healthcare professionals that were really rooted in the needs that we heard. So our listening sessions were conducted between May of 2024 and May of 2025. We conducted a total of 38 groups and reached 162 healthcare professionals across the 3 states where we conducted these sessions in. We used a purposive sampling strategy where we leveraged a number of different things, including our existing data on individuals who had received technical assistance from CORA. And then we did a lot of data mining to ensure that we had individuals in the sample that represented a broad swath of healthcare professionals working in this space, to maximize the type of feedback that we were getting across various professionals. We recruited individuals via email, and they completed a registration process that allowed us to ensure that we were only including individuals in our focus groups that were providing services in rural communities. We did incentivize participation in these listening sessions with a $99 gift card as a thank you, which helped boost participation. The sessions were conducted over Zoom, and we had smaller groups with anywhere from 3 to 6 healthcare professionals in breakout rooms. Each of the breakout rooms had a facilitator as well as a note taker to document the sessions, and we transcribed them verbatim for analysis. We use traditional coding strategies for qualitative coding strategies for our data analysis using a team-based approach. So initially we did test coding where all of our coders reviewed 1 or 2 transcripts, and we worked from our interview guide to create a coding structure, define codes, and get agreements. So we defined parent codes, which are the higher level themes, and then child nodes, which are the kind of sub-themes within that. And throughout the process, we met regularly as a team, really frequently in the beginning of the test coding, weekly, and then biweekly as we were working through the coding of the coding to make sure that we were resolving any discrepancies and further refining our codes as new themes were coming out through our analysis. We did all this in vivo. In vivo software. And once we were complete, this using in vivo allowed us to sort codes and cluster them in related groups, and teams looked across those for patterns and similarities. We also created a large Excel database once we were completed with our coding that allows us to sort by primary themes, sub-themes, and states, so we can look at the differences between the states. So this really helped us take what we had done from our coding and in vivo and put it into a user-friendly format that will help us make sure that we can draw conclusions and disseminate this effectively. So I'm really going to focus today. We have a ton of data from these focus groups, but what I'm going to present on the data is what it was used by Gail to inform the scholarship program. So we're going to focus a lot on the information we got about mood in rural communities. There were some high-level cross-cutting themes that I did want to share today because I think they're important for context. And so the first is that there was widespread agreement across a variety of healthcare professionals, from working in the risk reduction space, the treatment space, the recovery space, that rurality really increases the challenges that they face engaging and retaining people in care and services for substance use disorder. And it also hindered their ability to really be flexible and meet people where they were, not just because of geographic barriers, but other challenges in the rural space. Another key theme that came out is that participants noted a need for more opportunities for community for persons with SUD. This comes out a lot in our data, that individuals who are in their recovery journey in rural settings often feel very isolated and are seeking opportunities for shared experience and support within their communities. And oftentimes those don't exist because of geographic barriers and distance. And then finally, health-related social needs was a theme that cut across all of the 38 sessions that we have. these challenges are exacerbated in rural communities. I know addressing health-related social needs is a challenge for everybody, but in rural communities, transportation, lack of safe and affordable housing, and then a dearth of job opportunities are really high-level barriers that were cited by our healthcare professionals in our focus groups. But Katie and I also hear this all the time from individuals with lived experience, that these are challenges that really make it difficult for them to initiate in treatment as well as maintain engagement in their treatment and recovery journey. Shifting to discussing specifically what we learned about mood and prescribing buprenorphine, participants reported that there were widespread skills and willingness and capacity to address opioid use disorder through mood. They largely perceived that removing some of the barriers, such as rules and regulations around prescribing that have occurred after COVID, have really helped them expand mood opportunities in rural communities. Several providers noted that, as I noted earlier, that while prescribers are willing to engage in mood, that oftentimes they have unfilled capacity due to lack of patient referrals or the systematic barriers that I just discussed related to health-related social needs that make it hard for patients to engage, as well as the systematic stigma that is exacerbated in rural communities. One thing I wanted to point out is that in many of, in both Vermont, New Hampshire, and Maine, that participants reported that they might be the initiating prescriber, but that they then refer people out to the spokes, so to say, from the hub to transitioning into long-term care and more permanent prescribing. So do that. When we asked our healthcare professionals what helps facilitate their engagement in mood prescribing, a number of things came out. So there has been an expansion of care coordinators, patient navigators, and referral centers across our region that really has helped patients access care and has helped providers coordinate that care. That was cited as a major facilitator to expanding mood in communities. In addition to that, quick initiation and treatment, whether it be through an ED, a PC practice, or an ED to a hub spoke model, really helps facilitate those transitions of care. Treatment, again, going back to a lot of the changes that have happened in policy related to COVID, the flexibility that has been introduced with the expansion of telehealth has really helped improve access to mood, as well as MAT voicemail, introducing flexible appointments and weekend and extended hours really have helped improve access in Northern New England. And then finally, recovery coaches, providers trained in co-occurring disorders, and specialized access points unique to our state. So in Vermont, the Blueprint, the Doorway in New Hampshire, and Obson's Liaisons. These are really organizations that are proactively seeking high-risk individuals and trying to engage them in care, have really helped facilitate pathways to care for some of our most vulnerable populations. Barriers, there's a number of barriers that were discussed, and I just want to review a couple of them here. I'll start with, stigma remains an issue. I know a lot of work has been done to address stigma, but providers and the healthcare professionals that we spoke to indicated that there's still stigma related to patients with OUD, as well as against stigma related to mood as an evidence-based practice. We found this in our needs assessment work earlier, and we continue to hear that from providers in the listening sessions that we conducted over the past year. A lack of training for treating people with OUD and a lack of staff training contributes to low provider confidence. And we continue to hear that there is a need for peer-to-peer networks and champions to support individuals, particularly providers who are new in the space. They find that this networking improves their confidence in providing care. They have someone they can turn to if they have a really complex case. A lack of communication and clear communication channels to facilitate care coordination came up as a significant barrier, particularly between health systems and organizations that are working together to provide care across the care continuum. The communication pathways are often not clear or non-existent, and that's a significant barrier. And then finally, workforce turnover and a lack of professionals, it's particularly in the behavioral health space, affects the stability of patients as well as an organization's capacity to maintain their mood patient panel. So these were kind of the top barriers that were cited in our listening sessions. One of the things that we did at the tail end of our listening sessions was really ask participants, what could we do? What can CORA do to help address some of these barriers that you've discussed with us? And there was widespread agreement that improving provider comfort in treating persons with opioid use disorder and using mood was high on the top of priorities, as well as enhancing capacity for co-occurring mental health disorders, which is why this is one of our areas we're digging in on. And so the kind of 4 buckets that rose to the top as themes for training and resource needs were regular updates on best practices related to the state of science, right? This is a field that is rapidly changing, and it's hard for busy healthcare providers to remain updated on prescribing recommendations, rules, regulations, and best practices. Additionally, we heard that there was a need for educational opportunities to learn more on how to effectively provide patient-centered care using strategies like motivational interviewing. That remains a high need. In addition, how to address pain management for individuals who currently are on mood. And then finally, as I just discussed, training on treatment of co-occurring disorders. I am now going to turn it to Gail, who is going to discuss how all of the information from our listening sessions was used to inform our scholarship and support program.
All right, thank you, Lindsay. I think I have this set up. You'll tell me, someone on the call, if it's not. Okay, so I wanted to just start by, I guess, reminding folks, because there's a bunch of us on this call, of who's on the sort of the local UVM CORA scholarship and support team. We have Elizabeth, Brady, and Peter here on the call, and then we also have our colleague Martha Whitfield, who has helped with the design of the program as well in the delivery, and she's at UMass Dartmouth. So we've already talked about the learning objectives, and Lindsay covered the first 2. The second half of the conversation today will be on these last 2, which are to describe the structure, objectives, and intended impact of UVM CORA's opioid and substance use treatment training scholarship program, which is actually a mouthful. So we internally tend to just call it the scholarship program for short. And then next, to explain how feedback from healthcare professionals has shaped program design and informed broader strategies to support rural primary care teams. So our overall rationale for the pilot project is to provide evidence-based training on MOUD as a way to promote increase treatment capacity in rural primary care. And so the aims of this pilot are on the right, to identify key challenges faced by rural providers, to design a training program focused on supporting the use of MOUD, followed by virtual ongoing support, to implement the course and evaluate its impact, and then to disseminate the information on the model. Just for context, the listening sessions were done after our team had held 3 scholarship events in the first funding period. And then I'm going to talk about the development and refinement process of those first 3 events, and then how we wove in the results of the listening sessions into our 4th and most recent event. So to start this iterative process, we took advantage of 3 sources of information, the first being that baseline needs assessment that Lindsey referred to, and second, a search of the evidence-based literature. And then 3, we called on the expertise of our affiliated clinicians who are actively treating individuals with substance use disorders in various contexts. And so through our review of the literature, our baseline needs assessment and findings, and the expertise locally, we compiled a list of barriers to caring for people with OUD and developed strategies for addressing them in our training. And this table is dense. It's too long to read in detail, but I put it in here because we will be sending out the slide deck, and it's available to people who really want to dive into that. But I'll just highlight a couple of examples. First, we learned that rural providers didn't have access to addiction treatment experts for specialized consultation. So we made sure to provide ample opportunities for trainees to work with our SMEs during the session and afterwards. We have a lot of different speakers who come throughout the course of the training period. So they get to meet people with different levels of expertise. And then another example is that our survey respondents said they felt isolation from their peers who share similar challenges. And so we devised a program that brought together practitioners from different areas who shared common concerns. The content of the training was designed to address the barriers, as I mentioned. So we had instruction, discussions, educational activities by Peter, Brady, Martha, myself, and other members of our faculty and our clinician advisory board. A unique feature of our program is that we solicited applications from practices, not individuals. So each practice that applied could bring 4 members. And our rationale in doing that is that we would have a bigger impact on practice change after the program if there was a critical mass of staff and providers who were all exposed to the same content, instead of the typical CME opportunity where this can be a one-off, one provider from one practice goes. And we call it the scholarship program because we covered travel, lodging, reference books and materials, and free CME credits. The program is held on 2 consecutive days with material presented in a variety of formats. Somehow this pie chart isn't showing as it should. I have percentages for all of them, but you'll have to take my word for it that these pie slices represent physicians, advanced practitioners, some administrators, some behavioral health providers, and some peer counselors. And a few months after the event, Peter and Brady visited each site to consult on cases and generally encourage the practices to implement the lessons from the in-person training. We evaluated the program in 3 ways. First, we surveyed the respondents. Second, we documented our own observations about what went well, what changed pretty much immediately after, so it was fresh in our minds. And then thirdly, we documented observations during those practice site visits that I mentioned. Our post-program survey showed very high ratings, showing that participants found value in the content and intended to implement it. Content on motivational interviewing was especially valued. And at the 2 months post-program, participants indicated that the program had increased their capacity and willingness to treat OUD, which is very satisfying to us since that was one of our primary objectives. And our own observations as program developers were several here. Inviting multiple practices promotes collaboration and scaling opportunity. One of the things that didn't show up on the previous slide was that Of the 3 sessions that we held, the first one just had 1 practice that was invited. And then the other 2, we had one that had 3 practices, one that had 4 practices. And we really felt like having multiple practices promoted that collaboration and scaling opportunity that, well, Lindsey mentioned that this is something that has been shared by a variety of sources of information about what people need. But also that small program size enabled, more interactions and just more personal, personal context. So we wanted to keep it small enough. So we kind of settled on 3 as being our small enough, but being able to scale it. And identifying participants' needs ahead of time enabled us to tailor the curriculum a little bit. I mean, we have a solid curriculum that we know that are core things that we need to cover, but sometimes we have groups coming in that may share a particular perspective or, have needs in a certain area. So that's part of our application process, is to understand those needs. And then presenting real life cases allowed for personalized consultation. We learned this kind of as we went too, that people really like the cases. Some of the lectures that we did involved cases, but we now ask each practice to bring their own case of someone that they're currently treating that they have questions about. And we, call the resources of all of the providers in the room to be able to advise on specific questions. And then these reverse site visits, Peter and Brady went and did all of these visits, and they found that interdisciplinary work that was done at the event really did improve team collaboration post-event. So each practice had, maybe a prescribing physician, a behavioral health provider, administrator, and a peer counselor. And a lot of them say, we've never sat down as a team for this long, to talk about our practice and what we're doing and who knows what, and what do we need to implement and those things. So that really had a big impact on them, that carried over. Motivational interviewing was readily implemented, and it improved communication within the team as well as patients. Avoiding stigmatizing language was an interesting one, because we talk about stigma, but talking about it and then making changes in your verbal behavior are sort of 2 different things, that it really requires kind of repeated exposure to information about what language is stigmatizing and what some alternatives are. And so that's kind of an ongoing training need. And then, of course, there's going to be socioeconomic issues, co-occurring mental illness, and really lack of referral options in rural areas that our program sadly wasn't able to fix. Okay, so then Lindsey presented the listening session findings, and I'm just going to revisit a couple of her slides to illustrate how the listening sessions findings were relevant to our sort of iterative process. So as Lindsey said, they identified barriers to prescribing buprenorphine and specifically uncovered practitioners' experiences of inadequate training, workforce challenges, and stigma. So just these 2 bullets in particular are relevant. The lack of initial training in treating OUD and lack of staff training contribute to low provider confidence. And they also cited a lack of a peer network or champions for MOUD in their regions. And then stigma, as I said, remains an issue, stigma toward patients with OUD and stigma toward MOUD as a form of treatment. And then so regarding the training and resource needs, this was the last of the summary slides that Lindsey presented. This was really valuable to us. A theme was that it was challenging for practitioners to keep up to date on the evidence-based practices, and that many providers felt uncomfortable treating OUD. And these 4 bullets with the training and resource ideas from focus groups were really highly relevant to what we've been doing. I won't read through them again, but just to reiterate the value of having that information. So the listening sessions confirmed what we've learned from our other sources over time with the iterative implementation of the work, as well as, the literature and the baseline needs assessment. And these listening sessions were all very consistent with each other, which is reassuring that we're kind of on the right track with regard to what we're doing. So first, the purpose of the program has always been to increase provider confidence and comfort in treating OUD in order to increase the treatment capacity. Secondly, the findings reinforced our priority curriculum areas that have been a focus since the program's inception, like MUD prescribing. So we've always talked about it, but in our most recent program, we targeted in our looking at the applications, we really wanted to reach sort of more novice prescribers who maybe weren't as comfortable, hadn't started prescribing or only prescribed for a few people. So we had separate sessions on induction phase and maintenance phase and dosing. Stigma has always been a focus. I'll say that again. The counseling techniques. So as a result of these listening sessions and other feedback, we expanded our coverage of motivational interviewing. Everybody loved those. We added more interactive components to it. Pain management for patients currently on MOUD is a commonly requested topic, and one of our subject matter experts does a case-based interactive session on this, which is really helpful. And finally, treating co-occurring behavioral disorders is just one of our most requested sessions. It's something a lot of people ask about. Third on this list, the findings reinforced the program design of bringing multiple teams together within the same region so that they could have that sort of sense of they're not alone, they have some camaraderie and people who are experiencing similar challenges. And then fourth, the findings reinforced our emphasis on evidence-based practices and current research, which is a foundational focus of overall since the beginning. So that brings us back to the current iteration of the scholarship program, which is based on all the preceding ones, plus the new insights we got from the listening sessions. So in May of last year, we had a scholarship program event that was specifically for Vermont practices. And this is the first one of our new funding period. There was a competitive application process and we accepted 3 practices. And then the new part of this is that the post-program support, instead of being the outreach visits to the practices, we had a series of clinician office hours. Let's see. So yes, the format is consistent with our previous events. And then I already mentioned these priority topics. To go through these again. All right, so the program is sort of a 1-2 punch, with the on-site 2-day program being first, and then the post-program support being the other. And the support this time came in the form of these monthly online, Zoom 1-hour consultation with each practice separately. And these Zooms were open to anyone at their practice. It didn't just have to be the ones who came to the session. And in fact, that was one of the big advantages that the program said, was that we can now, give more exposure to this information to more people on our team so that everyone kind of understands for example, the latest evidence on, what's the most effective. Okay, so we have some findings from that program. We have some program developer observations, support phase observations, and then some survey data. And so what we noticed is that we really need to ensure adequate time for Q&A at the end of each session. That's always a struggle. I don't think it's unique to this program either. And then to increase the interactivity, as we've gone, I think, made it more and more interactive, and people really like those. We get good feedback on that. And, maybe sort of some polling, just maybe play around with what we can do. There's some polling technology to try. And then maybe having more discussion at the application stage about sort of knowledge gaps and patient populations that are being treated and their comfort levels. Whoops. And so then on the support phase, just logistically, as you probably all know, providers are very busy, and trying to find a time for them to attend. We had time set aside for this, and that just didn't work. So we arranged to meet them during their meeting times, which was much easier to get a larger group of folks to do it. And then we want to just be flexible and open to considering a wide range of ways to support people. So the visits that we had done, there's a few reasons for making these changes. I won't get into the details, but one of them was we found that not everyone really responded to that kind of support. So some people ate it up and they wanted us there all day. Other people were like, okay, we'll take it over a noon hour, and they just weren't necessarily. Either one is fine, but we also found kind of similarly Some people responded to the, having 1 hour during their lunch hour, like Zoom call, that's perfect. It fit right in. They could be brief about what they wanted to get out of it. But on the other hand, sometimes people struggled with setting an agenda, so maybe we need a little bit more proactive with them about how can we make the most of this time that we have together. So here's some survey results. This is, there's a lot of data. I'm not going to get into the weeds here, but I just wanted to show you some trends. So this was a question about knowledge that started with, if a person came to me and confided that they were experiencing opioid use disorder, I feel confident that, and then there's sort of 4 questions to follow. Each of them was done pre and post. So the questions were, I understand the pharmacology of MOUD. I understand how to evaluate a patient opioid withdrawal. I understand how best to apply MOUD clinically, and I can identify patients who are appropriate for treatment with buprenorphine. So what you'll notice just trend-wise is that, so just to orient you to the response option. So red is strongly disagree, orange is disagree, white is neutral, light green is agree, and dark green is strongly agree. So you'll see with the pre, which is always the top bar in each quadrant, that you have some strongly disagree and disagree options and a lot of sort of neutral. But by the time of the post, and this is like immediately afterwards, we had pretty much everybody saying they agreed with all of these things. There was, I think, 1 person, 9% is probably 1 person who was neutral on understanding how best to apply MOUD. So this just demonstrates to us that their level of knowledge has increased. And that's a self-reported thing. It would be great if we could, get into their brains and know exactly what they did and what they've applied. But we have another survey at 6 months that we just got data back for that are not prepared for me to present this time. Okay, and then we had really good satisfaction ratings as well. Oops. That the program addressed issues that they face in rural practice. They're satisfied overall, and they'd recommend it to others. And upcoming in April, we'll be doing a program specifically for New Hampshire practices. We selected 3, and we are refining the curriculum based on sort of their interests and needs and knowledge gaps and preparation. And, this is about the time when we also start initiating the logistical arrangements to have a contract with the hotel and, all those things that have to go into a program like this. And we also plan to do a program specifically for Maine sometime this fall, hopefully, and then in Northern New York or for Northern New York sometime next year. So in conclusion to this part, we know there's an opioid epidemic, and we know it's worse in rural areas. And we know that rural providers need support in treating OUD in these regions that don't often have specialist referrals options. So we're thinking and justifying that programs like this one can support rural clinicians in overcoming some of their barriers to offering OUD treatment, which will lead to increased treatment capacity and hopefully lead to fewer tragic consequences from OUD. So thank you. I'll stop sharing. I think.
Thank you, Gail. This is great. I'm gonna see if I can share my screen. I don't know if I can. But I guess I can. Hold on a sec. Okay. So thank you, everyone. We're so delighted that folks were here. This was a really such a fascinating presentation. I am going to launch this quick poll, and hoping that enough folks can stay and do this with us. It's right there in the center of your screen. People see this, right? See the poll? Good. So if you can fill that out, I'll give you about a minute or less, and then I have a couple of comments, and then we do have some time left over for questions. We had some questions come in to the Q&A box, and we'd like to get to those. So We will do that shortly. Just going to leave the poll up for a few more seconds here. All right. All right, I'm going to turn off the poll. Thank you very much. If you didn't get a chance to do it, that is okay. You will still be able to get your continuing ed credits. And as I mentioned, you will receive an email next week with the recording for this webinar, as well as instructions on claiming your continuing ed credits. As you may know, UVM CORA is one of 3 rural centers of excellence, which was mentioned earlier today. And this slide shows the 2 other centers as well as their websites if you want to join them or look into them. We also, all 3 belong to a clearinghouse, and there is a website which is called the Rural SUD Info Center. You can find that at ruralsudinfo.org. And here we provide some context for the information in this presentation and just explain its relationship to UVM CORA's funder, HRSA. And now I will hand it over to Eleanor Broy, who will facilitate your questions.
Thank you. I'm now going to read through some of the questions that we've received during the session. First question, has access to telehealth helped in rural areas in New England? This attendee is a provider and believes that it has.
Yes, that was one of our primary themes and was found as a facilitator. So the expansion of telehealth, particularly after COVID and the continued ability to provide care that way there are still some challenges because many people don't have access to computers or phones to support telehealth. But for those that do, and for organizations that can provide people with that equipment, it has greatly increased their capacity.
Great, thank you. This question is also for you, Dr. Smith. Can you say more about why providers cited rurality, aside from transportation barriers, as a factor that made it more difficult to meet patients where they are at?
Sure. This is for my friend Ann Connors. Glad to see you on here today. So really what we meant by that is that there is a lack of infrastructure, particularly in our very rural communities, that don't allow providers or limit providers' ability to refer people to the appropriate level of care or connect them with supportive services because they simply don't exist. So they're defaulting to what's available in the community. So this was talked about a lot in relation to residential treatment, intensive outpatient treatment. So if someone's in need and those services aren't available, they're defaulting to whatever they can connect someone to. So they don't have, because of the lack of infrastructure, it limits their ability to really tailor the types of services and referrals that they're providing people because they simply don't exist in the service area.
Thank you. Are there specific materials we use to provide education on avoiding stigmatizing language?
I'm happy to take a crack at that one, knowing that we're nearing the end. I would say the materials to support stigma reduction are actually really robust. So in the training program, we sort of present our own collection of information, including literature review on studies that have shown the impact of reducing stigma. But most large national organizations have really great resources, and the ability that CORA has had to provide sort of, help sheets and that type of things, those that, like the community rounds webinar, those have been, on pause, some of them, as we're reviewing prioritizations. But I believe that CORA has had a sort of stigma resource page for support in general. I think what Gail mentioned earlier, sort of knowing the information around stigma reduction is only the beginning of the challenge, and then sort of following up. So one of the things that we did with teams is sort of check in with them afterwards and ask them to work together as a team, be open to feedback, and sort of have an sort of integrated process where they can give each other feedback on reducing the impact of stigmatizing language, particularly. So I hope that's helpful. And then we think some of the psychotherapeutic training that we work on, including motivational interviewing, is of itself really helpful on identifying patient-centeredness and other means that can help reduce stigma.
Okay, I think that is probably where we need to stop for the day. Thank you again, everyone, so much for joining us, and thank you to our speakers and our panelists for being here and for all of your great work. As always, if you have any further questions or comments for our presenters or panelists or for CORA, please feel free to contact us at cora@uvm.edu, and we hope you have a wonderful afternoon.